Good. So in this graph, it is not normal. It is absolutely, there is a high fetal hemoglobin, but can it be normal or not? So that is the next question. So the importance is that any of these techniques are not enough to make any diagnosis of any hemoglobinopathies or any thalassemias. So no single technique gives us that liberty to say it is a pinpoint of this particular diagnosis. So we need a lot of things to make a final diagnosis. That is complete blood count with reticulocyte count, what is the RBC indices, RDW, what you are looking in peripheral smear, what type of RBCs you are seeing, are you seeing NRBCs and other, and what are the morphology of that. And then we can use these techniques, either electrophoresis or HPLC or capillary electrophoresis. And in case of doubt, we have to do parental screening. And sometimes all these things, even not able to pinpoint the diagnosis, then we need medical studies also. What we are missing all over there is clinical history, which is very important. So we should know what is type of severity of the anemia since presentation, whether it is from birth or after few years or days, whether they require transfusion, jaundice, gallstone, intermediate type, or whether they are symptomatic or what is the family history. So as you told, two diagnoses of that is one is thalassemia major and other is hereditary persistent of fetal hemoglobin. So this is the same graph. On the basis of history, I can tell you so many diagnoses. If I say it is a cord blood sample of a neonate, then Dr. Njot, what is your diagnosis?
Then it will
with
be
the same
normal.
HPLC.
Yes.
So it will be the normal, because cord blood contains more than 97% of all blood of is easily mainly fetal hemoglobin only. So it is normal. The same graph, if I say it is 10 month of old baby who is severe anemia and requiring transfusion since age of 6 months. So what will be the diagnosis for this same graph with this history?
Then it would be thalassemia major, as the patient is requiring transfusions.
Yes. So it is thalassemia major, which could be transfusion dependent. Okay. So again, I changed the history a little bit. It is 4-year-old male who is requiring occasional transfusion, one transfusion in last year. So now he is 4 years old and required only one transfusion since birth. So this is the same graph we are getting in this patient also. What could be the diagnosis now?
Then it can be hereditary persistence of fetal hemoglobin.
They are usually, until unless they are deletional type, they are not requiring any transfusion. They are absolutely normal person, even they have more hemoglobin. Okay. So the diagnosis is thalassemia intermedia, which is a syndrome where lot of different type of hemoglobin come under. And if I say it is a 18-year-old male which is totally asymptomatic, then it is definitely homozygous hereditary persistent hemoglobinopathies. So what are the different modality to estimate these hemoglobin variants?
So first we go with the CBC or the PBF.
Oh, that is okay. Now we are specific to estimate the different hemoglobin variant.
Electrophoresis, hemoglobin electrophoresis, and HPLC, and if we want molecular studies can also be done.
Yes. So the old time, and still we use this technique of hemoglobin electrophoresis, where the principle is basically different variant of the hemoglobin have different charge. So on the basis of that, we use this property, and when we applied a electric field, these on either on paper or in gel, agarose gel, when they applied inside the electric field, they separate, okay, on the basis of their charge. So that can be done either on alkaline pH or acidic pH. But the catch is here, those different hemoglobin variant who has the similar charge, overall charge, they will not get separate. Okay, so like this is your normal, so it will come move here on the basis of their charge and structures. So they are differently moved. So for this technique, usually previously we used to make these agro gel on a slide, then make a bell and then put that hemolyzate in it and put this assembly of electrophoresis and then it will be. But nowadays we are we have this automated system which can ready to use gel and you can get a better picture of these separation of these different hemoglobin variant and you can measure it by the densitometry also. So as I told that they can be either on alkaline pH, so on that is the most common one where it is separated from A to C, E, O, Arab, and then ST, that's sickle, T, Punjab, G or Lahore. Then fetal hemoglobin, then normal A hemoglobin, and fast being hemoglobin like J, Merit and H, etc. The advantage of doing in old time when we are not able to separate S and D, then we use this acidic pH for moving. So the next technique is capillary zone electrophoresis. So capillary electrophoresis is very powerful technique to separate these hemoglobin variant, and many labs are using this technique for analysis of these hemoglobin variant. So to understand how it works, we have to understand how it their principle. So here is the buffer reservoir, and a capillary is connected to this. And in this reservoir, there is two platinum cathode, which is supplied by the high voltage power. And the sample is injected from one side and it is detected on other side. Usually the detector is towards cathode because all the hemoglobin variant, they move towards the cathode. So better understanding, we can understand if what is electroosmotic flow and what is electroosmotic mobility. So basically electroosmotic flow is here the silica, this capillary which is made of silica that is mainly negatively charged, and the buffer who contains both cation and anion. So these negatively charged surface attract these positive anions and they make a fixed layer. Another, there is more, still it is not fully saturated, so more of the cations comes towards this capillary wall. This both layer is called electric diffuse layers, and in the center part of the bulk solution that contains both cation and anion of the same concentration. When we applied the electric field, that is anode and cathode this side, so usually this layer is positively charged, so whatever the concentration over here of negative and positive ions, they move towards the cathode because these are mainly here the maximum part of it is made of the cations. So that is what is electroosmotic flow. The second part of which governs the mobility of these analytes is electrophoretic mobility. It depends mainly upon the charge of the molecule, that is directly proportional, and inversely proportional of the size of the molecules, size and shape, and the viscosity of the buffer. So suppose here these are neutral, it is a positive and negative charge. So how they move? So they, according to the charge of this molecule, they move in this way. This is this is cathode and this is anode. So they move according to their charge. So the ultimate, when how these molecules move in this capillary zone electrophoresis. So on the basis of the charges, the electroosmotic flow is always greater than the electrophoretic charge. So whatever movement is there, it towards the cathode. So neutral has no charge, so the ultimate force is electroosmotic force. However, for the positive cations, electroosmotic force as well as electrophoretic charge both will be determined for this. However, these anions, they move towards the anode, but as I told, the electroosmotic flow is more than this electrophoretic charge. So ultimately, they come towards this side. So what we get over here, the movement of different type of the analytes, they moves according to their charge only towards the cathode. That is what I try to explain what is happening inside the capillary zone. So we inject towards the anode, and on the basis whether they are having positive charge or negative charge, ultimately they go towards the cathode, and here they will detect. So in capillary zone electrophoresis, we get these different zones and the separation of these different hemoglobin variant. The most commonly used technique is HPLC, which is cation exchange high performance chromatography. So this is the pictorial representation of the how it looked like. So basically here is two phase. One is stationary phase, which is made of silica gels, and they are strongly negatively charged layers. And other is mobile phase, which is different type of buffers. So along with the buffer, is the sample injected at this side, which is goes through this capillary, and finally, on the basis of their charges inside, they will detect it at different time, and which convert into a histogram. So let's try to understand what is happening inside this capillary. So this capillary is strongly negatively charged, and at the alkaline pH, their hemoglobin is positively charged. So along with buffer, different type of hemoglobin will pass through this. So these different hemoglobin has different charges of positively charged. So on the basis of affinity, they attach to this negatively capillary, and then when we pass through this low ionic buffer, only which is the weak affinity, they elute first. When we add the other strong buffer, then moderately, and when the totally it is replaced by the strongest buffer, then it will move all the hemoglobin. So that is what we got over here. That's why we get these F as lowest affinity as compared to A2, and then maximum for the A, then maximum for the A2. That's why we get these peak at the different time period. So for HPLC, two things are very important. One is retention time, other is retention window. So what is retention time? Retention time is the time from the injection to maximum peak. So this is somewhere 2.6 or 7 for A2, A. And retention window, when it start appearing and stop eluting. So this is retention window. So that is how HPLC graph look like. So before interpreting any graph, we should always look this graph very carefully for a few things. Whether these baselines are flat, then what is your retention time of your A2, then all the peaks, it should not be like A2 comes before A. That means there is something wrong. Then total area, it should be in between 1 million to 3 million. And then your response calibration curve, it should not be on 0.8 and more than 1.2. So that is what we have to look for. And when we try to interpret any type of electrophoresis or HPLC or capillary zone electrophoresis, we always ask a question to ourselves whether all events we are seeing is expected, or there is any unexpected band or peak. So whenever we talk about bands means we are talking about electrophoresis. When we are talking about peaks means we are talking about HPLC. So if it is unexpected peak or band is there, what is the percentage of it? So it was whether we are dealing with thalassemia or hemoglobinopathies, or on the basis of how much this particular type of variant hemoglobin, whether we are dealing with heterozygous, homozygous, or compound heterozygous. So here I want to just clarify that the thalassemia usually like alpha thalassemia and beta thalassemia, where no new band will appear. Whatever A, F, and A2 is there, they either decrease or increase. In hemoglobinopathy like S, E, D, there is a new hemoglobin variant, so a new band or a new peak is appeared. So we have to have some room to interpret these things. So this is very favorite slide of Ruchi ma'am. She always say what is normal. So define normal firstly. So is it normal or this is normal? So definitely this is abnormal, this is normal. So we should know normal retention time or retention values of different hemoglobin and what are the percentage which we expect in a normal person. So usually less than 5 fetal hemoglobin, A2 use 2 to 3.5, and normal hemoglobin is usually 8 to 90%, and there should be no other abnormal peak. But in abnormal, these varies according to what type of different disease we are dealing with. So that will let us see in next few cases. And especially with the A2, it is very important to see the value. If it is less than 2, then definitely we are dealing with either alpha thalassemia or delta thalassemia, delta beta thalassemia. If it is 7 to 8 or not, it is 4 to 8, then it is heterozygous beta thalassemia. If it is 8 to 15, then definitely heterozygous A. 25 to 30, heterozygous E. And if it is 40 to 50, then heterozygous B era. And more than that, then we are dealing with either homozygous or compound heterozygous. So that is how we used to think about these things. So are you able to understand how we should interpret these different techniques which I just discussed? Am I audible?
Yes.
Yes. Yes.
Okay. So I think this is a background which we want to give you before we discuss with the next few cases. So anyone of you can pick this case number 2, which is 9-month-old child presented with complaint of pallor and history of recent transfusion 1 month back. On examination, there is mild splenomegaly, and his elder sibling has similar type of complaint of pallor and required transfusion every month. So what information you are getting from this type of history? Anyone can explain? Stopping you? Anyone? Unmute yourself and answer what explain this history. What is the diagnosis, or what are you thinking of after seeing this type of history?
So there is probably hemoglobinopathy because there is history of transfusion in both the siblings. Although the 9-month child has only a single transfusion 1 month ago, but the elder sibling is having transfusions every month. So we can think about some hemoglobinopathy in this.
Okay, so first thing, it is very clear there is a strong history of similar complaint, and the child is presented in early innings. Okay, so means it is inherited type of disorder. Okay, it is not what we are dealing with the regular any nutritional anemia. Okay, usually we don't get the same type of history. And other thing is required transfusion means it is severe. Okay, otherwise till 8 or 7 we don't transfuse the patient, we ask for some oral tablets or something. And there is splenomegaly, which is again point, it is something is there. So what you go for first, RBC indices and peripheral smear. So this is, can you interpret this RBC indices and peripheral smear? And on the basis of this, what will be your differential diagnosis and what the next investigation you would like to do?
Sir, HB is 6.7, that is, it is low. Then CV and LCH is also low. RDW is increased. And on peripheral blood smear, marked anisopoikilocytosis is seen. Then many target cells are seen. And RBC is seen. So this is.
So even if we calculate
yes.
the Mentor's index, sir, it is also coming.
Yes, that is important.
0.7.
Okay.
0.7.
So 6.7 to 4, there is rule of 3.
Yes,
That
sir.
RBC into 3 is equal to your hemoglobin, and hemoglobin into 3 is your hematocrit. So that doesn't fit in this. So usually, especially in heterozygous conditions of beta thalassemias and alpha thalassemias, that does not but it is not always necessary. If there is concomitant iron deficiency or megaloblastic anemia, okay, then this, or pregnancy or some other liver disease, so then these things indexes are not that good. Especially again in sickle cell anemia, where you usually get normocytic normochromic pictures. Okay, so then these type of rule of 3 will not help you. Yes, but definitely we have to look for this. Okay, I have not given reticulocyte count. So reticulocyte count in this patient, corrected retic is 0.5. Okay, so and can you explain the right side picture of peripheral blood picture?
Sir, there are numerous number of target cells. There's a teardrop cells are present.
Yes.
So with occasional NRBCs. Sir, just because
Yes.
Mentor's index is 13.7, still we can go for iron profile of the patient to see if the level of TIBC and the transferrin, even though it is coming like to the point that it is most probably a hemoglobinopathy, still we can go for that.
Yes. So always think about common things. So nutritional anemia is very common, but as we have seen in this history,
Yes, there's history
well
of
said.
confusion.
Yes. Yes. So elder sibling has similar complaint, and this child is also classically fitting in cases of where it is presented in early. Yeah. Otherwise, you have to always start with the if you seeing for microcytic hypochromic picture, you should think about whether we are dealing with nutritional anemia, and if you are ruled out, then you should think next. And these things is also indices, what you will tell is definitely going to fit. So now if it is microcytic hypochromic picture, so what could be the differential diagnosis as you told now, the history, if it is asymptomatic? Okay, so can you read what are the different conditions where you can find these? So usually alpha thalassemia carrier, beta thalassemia carrier, heterozygous E, D, homozygous Punjab, delta beta thal trait, HP Lepore, these can present all these classical RBC indices and microcytic hypochromic picture, but they are not asymptomatic and does not require any treatment. Okay, but if I say these patients are symptomatic, then what will be the differential diagnosis for symptomatic patient who is presenting with microcytic hypochromic anemia and they are not nutritional? What could be? Anyone? Just now you told, na, that thalassemia
Homozygous
usually,
fetal thalassemia.
which are the different hemoglobinopathies which can be present with symptomatic transfusion dependent type of, or intermittent or continuous or regular transfusion dependent, are either thalassemia major or homozygous thalassemia, HPS disease, unstable hemoglobinopathies, or homozygous delta beta thalassemias, or different type of compound heterozygous states. So come back to the case. So if I ask these 4 questions, it is suspected case of what?
So thalassemia major.
Yes, thalassemia major.
Major, sir.
And CBC abnormality includes microscopic pictures and severe anemia, microanisopreclusive and NPC. So what will be the next step for this?
Can go for sir HPLC, sir arms, sir amplification refractive mutations, or system for point mutations.
Okay, so usually initial stage we don't do mutation until unless we have some doubt, or we are not able to resolve these things, pinpoint a diagnosis on the basis of HPLC or electrophoresis or Capri-John electrophoresis. Usually the mutational studies done in those cases where it is ambiguity and we are not able to define it, or in cases of prenatal diagnosis, before prenatal diagnosis. But the question is here, suppose this child has received 3 days back or 4 days back transfusion. So can what we are going to get is mix of the disease stages and normal hemoglobin.
Yes, sir. Yes.
So what we should do, what a simple things we can do in such case, because we need to treat this child. Okay, so we need a diagnosis to confirm. So what one easy thing we can do to make a simple diagnosis, because whatever HPLC we will do, it's not going to give us a clear picture, because this child has been recently transfusion 3 days back.
So parental screening, sir.
Yes, good. So this is the patient, same graph. Okay, so here it is almost it is what we got, because there is some normal hemoglobin, some A2 and F. Okay, because this has received blood transfusion, that's why this type of picture. So we are not able to justify, because if it is, we are saying it is homozygous beta thalassemia, then it should be somewhere around 97% or 99%. Okay, but it is not. So when we did the HPLC of mother, it is heterozygous, A2 is 5.4, and the father is also having raised A2, which is 4.6. So on this basis, we can make a diagnosis that yes, we are definitely dealing with a case of homozygous beta thalassemia. Is it clear?
Yes, sir.
So in such situation, we can do this. So now I just hand over the things to Dr. Ruchi. From here, he will take you case now. Ma'am, are you there? Ma'am, unmute yourself.
Yeah, just a minute. But so is the screen visible?
Yes, please.
Yes, ma'am. Okay. So thank you, Dr. Dinesh, for making my talk simpler. And Dr. Dinesh has actually briefly discussed of what other common modalities are available routinely in a common hematology lab, which will help you to establish a diagnosis of a hemoglobinopathy. And he has discussed mostly about the techniques and their principles and how do they actually work and help us to establish the diagnosis of hemoglobinopathy. So I'll just take 2 slides to actually say when we talk about a hemoglobinopathy, what are we actually trying to say? So a normal adult hemoglobin, we all know, are made up of 2 alpha and 2 beta globin chains. And we can classify them into thalassemia syndromes, where there is a quantitative defect, meaning thereby it can be an alpha thalassemia or a beta thalassemia. When there is a mutation in the alpha globin gene, we call it alpha thalassemia. If there is a mutation in the beta globin gene, we call it beta thalassemia. If there are mutations or loss of the delta beta part of the gene, we call it delta beta thalassemia. So in all of these states, what is happening? The hemoglobin which is formed is normal, but the amount which is produced is reduced. Whereas then we have point mutations which result in variant hemoglobinopathies, which are known as qualitative defects. Here we have examples of sickle, HBD, HBC, and quite a few other lesser known variants. So here what is happening, that we are having a abnormal chain which is being formed because of the point mutation or the mutation, and this comes under basically the qualitative defect. Then there is a third term which we frequently use, that is the thalassemic hemoglobinopathy, meaning thereby that the amount of the protein which is formed is also abnormal and the quality is also abnormal, meaning thereby there is a point mutation, but because of that mutation, the chain which is formed, the protein which is formed is not a very stable protein. Hence, the protein gets degraded and it is simulating something like a thalassemia. So when we say thalassemic hemoglobinopathy kind of a picture, then probably we are referring to HBE, HB leopard, some unstable hemoglobinopathies, and hemoglobin constant spring. So leaving aside the qualitative defects, because they'll come to us either in an asymptomatic state, or if we have homozygous sickle, then we'll have accordingly, we'll have manifestations which Dr. Mukul can tell us how does he routinely encounter patients of sickle in his OPD. But when we are talking about thalassemia, then on one end of the spectrum, we have the thalassemia heterozygous states, that is one of the beta globin gene is affected, and we commonly call them as carrier or trait. Whereas at the other end of the spectrum, we have the thalassemia major, which are both homozygous in state, both the genes are mutated, the beta globin production is markedly reduced or almost absent, and this we call as transfusion dependent thalassemia. And in between these two extreme states, we have a condition which is known as thalassemia intermedia, right? So I'll start from the from the students. So Yogeshwar, how can you tell me clinically how all these three differ?
Yes, ma'am. So basically, thalassemia major would be transfusion dependent. The patients would require regular, frequent transfusions.
What would be the age of presentation for this such
and
case?
Young patients would be young patients. Thalassemia
How
major.
young? I also consider myself young. How young is young?
Children, basically, infants.
Infants, okay. So there is an arbitrary cutoff, and roughly we say if it is manifesting before 2 years of age, we call it thalassemia major, and 2 years we label it as intermedia. But now broadly the term it is used is either transfusion dependent thalassemia or a transfusion independent, right? Or a non-transfusion dependent basically. So that is about thalassemia major. What about these heterozygous beta thalassemias or the thalassemia carriers? How do they manifest? Yogeshwar, are you there?
Yes, ma'am.
Okay, let us pass on the question to Rajneesh. Rajneesh? Okay, then we have Neenu.
Yes, ma'am. Usually the thalassemia will be asymptomatic.
Okay, asymptomatic. Then how do we identify them? So they are asymptomatic, you correctly said. What would be the first investigation, maybe I can tell you, from which you can pick up a heterozygous state? Or you can suspect?
We can suspect it from a CBC count where the Menser index will be less than 30.
Okay.
And the peripheral
Dr. Mukul, after this, can you please little bit explain in broad regarding the clinical presentation, how you suspect these cases in your OPD?
Thank you, ma'am. Thank you, Dr. Dinesh. So what we have now is a classification known as transfusion-dependent thalassemia or non-transfusion-dependent thalassemia. That is the broad term which is used for patients who require transfusions on a 3 to 4 weekly basis. That is classical thalassemia major, or some patients of thalassemia intermedia or compound heterozygous stage who require transfusions are like that. This transfusion frequency for the previously called thalassemia intermedia could be up to 2-3 months also, but they are requiring regular transfusions. Otherwise, classically what we call the thalassemia intermedia is those patients, they require transfusion during periods of stress, during surgery, during pregnancy, when the normal hemoglobins go down. The classically thalassemia trait are asymptomatic patient, but when you are sitting in a clinic, the picture is not always that smooth. We know that these are always, in many cases, modified by nutritional deficiencies. And as we know that the prevalence of iron deficiency anemia in our society ranges from around 50 to 60%. So this obscures the picture of thalassemia trait or carrier in the CBC. So when we say Menzer index, it's kind of a overhyped index in that regard. Because many a times the diagnosis is not very clear. So what we rely in practice is, especially a micro hypo picture, very low MCV and high RBC count, which is not corresponding to that MCV. That is like kind of a clue which helps us in determining whether the patient has thalassemia trait or not. Invariably, in such a scenario, whenever there is slightest bit of confusion, go for both HPLC and serum ferritin test. Remember that iron deficiency anemia is diagnosed on the basis of ferritin, not on the basis of CBC alone. Since iron deficiency is very common, many a times some of these thalassemia trait patients may be requiring transfusions, especially if they are having history of blood losses or otherwise. So, that distinction sometimes becomes obscure in clinical practice. Over to you, ma'am.
Right. Thank you, Dr. Mukul, for summarizing it so nicely. So what I wanted the students just to go back is, and what you have actually brought out is, personally, if you ask me, do I calculate a Menzer index? I will say no. There might be people who are more fan of Menzer index, and I have absolutely no objections to that. But there are, in India, there is so high coexistence of iron deficiency anemia with beta thalassemia traits that many of the time I would say that you cannot just rely on that index. And as he pointed out, if somebody comes to me with a good going hemoglobin and a very low MCV and an RBC count which is actually going beyond that multiplication rule of 3, we will start suspecting that this is probably a case of beta thalassemia trait or a heterozygous beta thalassemia, and definitely put that sample up for HPLC. And I would like to remind everybody, because in the case just before this, the students started talking about the Menzer's index. There, the patient had a hemoglobin of 6.9, severe anemia, symptomatic, requiring transfusion. Menzer index is only for application in a suspected case of beta thalassemia trait, who is asymptomatic. So there was no point of discussing Menzer index in that case, जो 6.9 hemoglobin से आया है. अगर उसको थैल ट्रेट के साथ कोएग्जिस्टिंग इतना ज़्यादा आयरन डेफिशिएंसी एनीमिया हो गया तो वो ट्रांसफ्यूजन भी ले रहा है, ये थोड़ा ऑड बात हो जाएगी बहुत, है ना. उस कंडीशन में आई वुड एक्चुअली नॉट लाइक टू अप्लाई मेंजर इंडेक्स. You usually apply Menzer index for a condition like this, which is asymptomatic. And then again, thalassemia major को आप देखते हो कि usually बच्चा है like less than 2 years of age, or usually they come to you between 6 to 9 months of age, because it is at that time point when the protective HbF hemoglobin levels go down and the beta should have taken its place. But क्योंकि mutation है beta globin gene में, इसीलिए normal hemoglobin बनता ही नहीं है. And so they start manifesting usually after 6 months of age, and by 1 year then they'll usually have severe anemia, एक आध transfusion की history होकर के आएगी. And so that for us as a maybe at a tertiary care center, somebody that young who's coming with a history of transfusion and this kind of microcytic hypochromic picture, the first DD would be a thalassemia major. I agree, sometimes very severely iron deficient patients can also come like this. And the best is कि अगर parents को screen कर लो, like you people discussed, कि parental screening will give you the answer. So this coming in between to these two extreme spectrums is the thalassemia intermedia. Clinically, अगर मेरे पास मुकुल सैंपल भेजेगा कि मैम इसको ऑन एंड ऑफ जॉन्डिस है एंड ऑन एंड ऑफ एनीमिया है, एक ब्लड ट्रांसफ्यूजन इसको 2 साल पहले मिला था और अभी कुछ हुआ है एंड रिसेंटली रिसीव अनदर ट्रांसफ्यूजन. So I'll put this patient as a broad category of thalassemia intermedia. So why do I say thalassemia intermedia is actually a broad category. It is clinically defined. कि अगर ऐसा सिम्टम है तो हम सोचते हैं कि थैलेसीमिया इंटरमीडिया है. बट जीनोटिपिकली इफ यू सी थैलेसीमिया इंटरमीडिया could be due to multiple conditions. It could be either mutations of both the beta genes, one beta gene and another maybe delta beta or lepor or deletional HPFS, or there is coexisting of alpha thalassemia, or there is homozygosity of delta beta thalassemia. So the point is that thalassemia intermedia is a term which is used for that kind of a presentation, and genetically and when you do an HPLC, even a HBE beta compound heterozygous can also clinically present as a thalassemia intermedia. So when you have that history in mind, you should have your differentials ready mentally कि ये probably ऐसा कुछ निकलने वाला है. So with that background, if we go to the case 3, we have an 8-year-old male who presented with mild pallor, resident of Bengal, history of transfusion on and off, no significant other family history, and then there is moderate splenomegaly. So Sarangi, can you tell me what would you like to think about it if I say that we have to suspect a hemoglobinopathy?
Ma'am, I would suspect beta thal trait. So it can be HBE or
sorry, you said beta thal trait and then you said HBE.
Sorry, ma'am. Beta thal trait.
So why would a beta thal trait have a history of transfusion on and off? So the point is not well taken. Traits are usually asymptomatic, incidentally picked up. Majors are those who will be picked up very early in life, right? And when you have such a kind of age, 8-year-old, जो मेरे typical history अभी मैंने बताया आपको दे रहा है कि he has mild pallor, on and off transfusion, and if I say similarly on and off jaundice, so you would probably put the patient as a suspected case of thalassemia intermedia.
Intermediate. Yes,
So then what? And then we have,
क्लासिकली जो थैलेसीमिया ट्रेट्स होते हैं उसमें ऑर्गेनोमेगली नहीं होते हैं. सो if you are having splenomegaly, that means some kind of peripheral destruction is going on.
right.
Okay.
So अटक गई slide. Okay. So then the CBC findings are hemoglobin. Again, we have a moderate anemia, 8.5 hemoglobin. RBC count is on the higher side. Indices are reduced, 63 MCV, 17.5 is the MCH and 27.7. RDW is high, which is apparent from the smear. RDW is telling you that there is a lot of anisopoikilocytosis. We have microcytes, hyperchromic cells, and then we have a lot of target cells. NRBC, I'm not sure is visible in this field, but these were the findings of this particular case. So, if I before we actually go on to think where it is, there's one clue I gave you in the history that the patient was a resident of Bengal. So, anybody, Diljot, what is prevalent on the northeastern sides of our country?
HBE.
Yes, very nice. So when you see a case जो बंगाल से आया है ऐसी हिस्ट्री दे रहा है तो first thing that will at least come to my mind is suspect कि ये कुछ E के साथ he might be unlikely to be a homo HBE, but HBE is definitely high on the cards. This is what my HPLC graph is showing me. So can you continue, Diljot? What is it showing?
So here the HPF is 50.1, which is increased more than the normal, and when HPA2 is 51.4. Then so I was thinking of it is a double heterozygous with HBE, then HB Iran, because the HbA2 value is 51.4 around. So it would lie in the HB Iran would lie in that category, and then along with Thal beta.
Right. So now, so that is one DD. What else comes with A2? अभी हाँ दिनेश ने टेबल दिया था ना कि इतने से ऊपर है कि अप टू नॉर्मली 8% तक वी थिंक ऑफ A2 एज बीटा थैल ट्रेट का रिप्रेजेंटेटिव. बियॉन्ड दैट A2 में और क्या कोइल्यूट होता है?
HBD, if it's around 40%, A2 level is around 40%, then we can think of HBD.
हाँ, अभी तुमने मुझे बताया ना पेशेंट बंगाल का है तो तुम कंपाउंड हेट्रोजाइगस
HBE.
ई बीटा क्यों नहीं सोच रहे?
I said E beta initially.
अच्छा,
Compound
okay, you
double
said E beta.
heterozygous, HBE
E beta.
Iran, and
Right.
Haldi.
So how do we now solve the problem?
And we can also look at the parental HPLCs.
Very good. We can also की जगह ऐसा है कि we have to look. So again we answer these questions that it is suspected case of what? What does the CBC look like? What are the HPLC abnormalities? What are possible differentials? And how to confirm this? So thalassemia intermedia clinically by the history. CBC में microcytic hypochromic indices है, so it looks like कि beta thal का component तो साथ में होगा. Then HPLC में we are seeing that A2 is increased and adult hemoglobin is totally absent, indicating that both the beta globin alleles are affected. अगर normal होता कोई भी beta तो थोड़ा बहुत adult hemoglobin बनता, right? So differential diagnosis because of the ethnicity, presentation, and I am actually D Iran का incidence कम है. I'm not really sure. Maybe Mukul can say if he has actually seen compound heterozygous D Iran with beta thal. वो clinically कितना manifest करते हैं I am not sure. But I can tell you that compound heterozygous E beta definitely range from mild anemia to moderate to severe anemia at times of some kind of stress. है ना? तो ज़्यादा लैब में आपको ई बीटा के पेशेंट्स एनकाउंटर होंगे ऐसे जिसमें कि एफ भी इतना ज़्यादा होगा बिकॉज एफ इज़ अ काइंड ऑफ अ कंपनसेटरी इंक्रीज फॉर द डिक्रीज इन द बीटा ग्लोबिन जीन्स. तो जितना भी अल्फा बन रहा था वो गामा चेन्स के साथ जाकर के एफ बना रहा है. इट हैज़ हायर एफिनिटी टू कंबाइन विद द गामा ग्लोबिन जीन चेन्स एज कम्पेयर टू द HBE म्यूटेशन के बाद जो बना है. एंड डायग्नोसिस बाय पेरेंटल स्क्रीनिंग. एंड सो द मदर इज अ A2 is
A2 is 4.9, so thal trait.
yeah. So mother is a heterozygous beta thalassemia and father is a father. May I'll ask Sarangi. Sarangi, what does the father look like?
Intermediate.
Father looks like. What does the HPLC tell you?
A2 is 27.2%.
Right. So A2 is 27.2% and इस A2 डिवीजन में हमारे पास क्या क्या एल्यूट होता है? HBE. Yes. Very nice. The mother is basically a beta thalassemia trait and the father is a likely case of HBE. And why not HBD, Diljot?
For that, the A2 should be around 40% or so.
Right, very good. So अभी मैंने बताया ना because HBE is like a thalassemic hemoglobinopathy. So एक variant बन रही है chain and उसका production भी कम है. तो HBE का heterozygous states में usually it is up to 30%, right? Ideally if you have two chains, you expect कि दोनों beta globin genes से 50% बन रहा होगा. इसमें heterozygous HBE में एक chain mutated है तो 50% abnormal hemoglobin बनना चाहिए था, but लेकिन because E is the protein which is formed is not good quality, it gets degraded, so इसका percentage heterozygous states में it lies up to maximum of 30%. ठीक है, usually हम 25 to 30% के बीच में ही देखते हैं, right? So we have a diagnosis that the child is a case of compound heterozygous E beta thalassemia, right? So this was an example of thalassemia intermedia, right? Any questions, anybody? Case solved? Chalo, okay. So, Dr. Mukul can say something about how they see E beta thalassemias in their OPD?
So, as has been rightly pointed out, there are several clues. So, E patients, whosoever is either heterozygous or homozygous, they are coming, at least some kind of ethnicity is there from the eastern part of India, Bengal or other northeastern states, Assam and other states. All other states, they have a higher prevalence of E. D is slightly more common in the north west part of India, but the prevalence is not very high. Very occasionally, maybe 1-2 cases in a year, the heterozygous or the compound heterozygous D are diagnosed at our center as well. So it's not very common. But E is pretty very prevalent. Severity, as has been pointed out, so what we characteristically commonly tell our students is that 50% of E beta thalassemia behave like thalassemia intermedia, and 50% they behave like classically transfusion dependent thalassemias. So the severity is moderate to severe in most of the cases.
Okay, thank you. So we move on to the next case. We have a 16-year-old child born of non-consanguineous marriage, resident of Bihar, presented with pallor and jaundice, and there is history on and off of transfusion. The parents again are asymptomatic, and on examination the child had pallor and some hepatosplenomegaly. The counts clearly point out that there is anemia. The RBC count appears to be higher for the degree of hemoglobin, star 4 into 3, 12. I would expect a hemoglobin of 12 for that count. And then my MCV is on the lower side, and we have a reticulocyte count of 3.5%. So just on the basis of the clinical picture, can somebody say that we are probably dealing again with the case of थैलेसीमिया इंटरमीडिएट? सो मेरा लगता है कि मुझे लग रहा है कि मुझे ही बहुत फैसिनेट करता है ये एंटिटी. वी हैव वन मोर केस आफ्टर दैट आल्सो फॉर दिस एंटिटी ओनली. ओके, सो द पॉइंट इज कि अगेन वी हैव अ पिक्चर व्हिच इज नॉट सिवियर. थैल मेजर नहीं है, एसिम्प्टोमेटिक नहीं है कोई भी, क्योंकि कोई भी एसिम्प्टोमेटिक होगा तो आपके पास इंसिडेंटल स्क्रीनिंग के लिए ही आएगा या आप पिक करोगे. बट हियर वी आर डिस्कसिंग केसेस जो सिम्प्टोमेटिक है एंड दे हैव कम टू यू फॉर अ डायग्नोस्टिक वर्कअप. So this is what the HPLC showed us. So for a 16-year-old, we have a F of 100%. So anybody, what could it be? So definitely not thalassemia major, है ना? Major तो बोलना नहीं है इसको, because इसका age नहीं match कर रहा है. Plus इतना late हमारे पास आया है, and there is occasional history or there is on and off history of transfusions in the past, right? So what are the differential diagnoses of so much F at this particular age, right? There could be homozygous delta beta thalassemia. delta जीन भी नहीं है, बीटा जीन भी नहीं है, इसलिए HbA2 भी नहीं बन सकता और HbA भी नहीं बन सकता. सारा का सारा क्या बनेगा? HbF. और दूसरी कंडीशन क्या है? HpFH. दूसरा क्या है? homozygous LEPOR. What other compound heterozygous states like delta beta thal or a combination of basically 1, 2, and 3. So clinically, how does homozygous delta beta thal present like? Anybody? I think this will become slightly difficult for the audience which we have over here. So basically, a homozygous delta beta thal again comes as an asymptomatic to a picture like thalassemia intermedia ki stress hua to he has some degree of anemia. HPFH patients will be asymptomatic again. They will not come to you for a workup as a case of anemia, क्योंकि HPFH में पहले ही जो भी माँ की तरह होता है, fetal hemoglobin is a very protective hemoglobin. So किसी भी reason से अगर HbF किसी का ज़्यादा है तो they are usually their degree of symptoms and the severity of anemia reduces. Then homozygous LEPOR and other compound heterozygous states also present as thalassemia intermedia. So amongst these 1, 2, 3, 4, my likely diagnosis is between, except for 2, it could be any of these 3. Okay, is the audience with me? Alvia? Ninu? Ninu? Yes. Are you following what I am trying to teach? Okay, very nice. Okay, so how to proceed? So you have a 16-year-old male who is symptomatic and has anemia, has a thal intermedia like picture, and HPLC already done. अब कौन बताएगा कि क्या करना है आगे? योगेश?
पेरेंटल स्क्रीनिंग.
वेरी गुड, मतलब एक्सीलेंट आंसर. मुझे ऐसा लगता है कि हीमोग्लोबिनोपैथी के लिए कभी भी कुछ भी आंसर करना हो तो हमेशा बोलना चाहिए पेरेंटल स्क्रीनिंग. दैट इज द बेस्ट आंसर you should give. And we see again the mother is having a hemoglobin of 11.4 and a father of 13.7. I would say it's kind of asymptomatic, clinically asymptomatic. RBC count higher side for both of them, and you have a microcytic hypochromic picture, not significantly high RDW, and both of them had a F peak of approximately 18%. So what are they probably looking like? You would call them. Diagnosis is, what are the mother and father? What will I call my parents as? We have a F of 18.7%. Anyway, when we have a F of between 5 to 30%, हमारे DDs क्या होते हैं? Heterozygous delta thalassemia and or usually heterozygous HPFH. But अभी मैंने बताया कि HPFH तो symptomatic ही नहीं होते, तो इसीलिए it is quite likely that these both the parents are heterozygous delta beta thalassemia and the son is basically homozygous delta beta thalassemia with a clinically a thalassemia intermedia like picture. So based on the clinical findings, the red cell indices and the distribution of HbF, which can be done either by the Klee-Hall-Bethke test or by F cells on flow cytometry, I would say usually last test अभी हम लोग तो नहीं करते अपने center पर, but this is how traditionally it has been taught to differentiate between HPFH and delta beta thalassemia. So since both the parents are like delta beta thalassemia heterozygous stage, so my child is basically a case of homozygous delta beta thalassemia. एज अ रेजिडेंट मुझे ये टर्म बिल्कुल समझ में नहीं आता था और जैसे जैसे फैकल्टी होने पे समझ में आना शुरू हुआ सो मे बी आई थिंक दैट यू नो इवन एट योर लेवल थैल ट्रेड समझ में आ जाता है, थैल मेजर समझ में आ जाता है, थैल इंटरमीडिएट समझ में आ जाता है, तो इट इज गुड इनफ. But if you can understand delta beta thalassemia, it is basically the green part is basically highlighting that delta beta genes are getting deleted and same kind of genetics is involved in HPFH also. But in HPFH, the compensation of the gamma globin gene chain is high and hence HPFH is usually not that symptomatic, whereas delta beta thalassemias are symptomatic and usually if I say microcytic hypochromic indices are found in delta beta thalassemia. And when you do HPLC in a heterozygous state, they will show you elevated HbF between the tune of 5 to 25 or 30%. ज़्यादा higher रहता है in HPFH as compared to delta beta thal. बहुत सारे तरह के डेल्टा बीटा थैल के नाम दिए गए हैं, घानियन, इंडियन, वियतनामीज एटसेट्रा एटसेट्रा, एंड ये नाम दिए गए हैं ऑन द बेसिस ऑफ द पार्ट और द सेगमेंट ऑफ द जीन विच इज गेटिंग section of the gene which is getting deleted. In India, HPFH3 variant and this Indian variant of gamma delta beta thalassemia or delta beta thalassemia are the commonest. If you still want to, for me it is okay, but if you still want to go ahead and confirm the diagnosis that ये heterozygous compound कि ये homo delta beta thalassemia है, you have genetic workup. What is happening? Your gene is getting it breaks at 2 points, that is A over here and over here, and then there is an inversion. That is why the name of the mutation is Asian Indian inversion deletion, and you can run a simple PCR and that will confirm your diagnosis. Normally इस extent तक clinical हमको जाने के लिए कम ही कहते हैं, and हम by the parental HPLC and the clinical of the child, we are usually able to establish and confirm that we are likely to be dealing with a diagnosis of Asian Indian inversion deletion, delta beta thalassemia. Case 5, so 16 को मैंने अब 6 कर दिया है मुकुल. So this is a 6-year-old male child born of non-consanguineous marriage, again presented with jaundice. There is history of on and off transfusion even in this child, but it was beyond after 2 years of age, and on examination again the child had pallor and splenomegaly. Again we have hemoglobin of 7.6, some RBC count which is increased, microcytic hypochromic indices and a retic count of 3.5%. Okay, I double हुआ वही वो कह रहा था मुकुल. So this is what the HPLC is telling me. Anybody? कौन बच गया है? Voluntarily आ जाओ. Can somebody read the HPLC for me? No volunteers?
It can be, ma'am.
Yeah, please.
Ma'am, it can be ma'am, it can be thalassemia trait with the iron deficiency, ma'am.
Thalassemia trait with an iron deficiency के लिए, if we look at this picture only, so there is a history of on and off transfusions and there is jaundice सो थोड़ा सा ऑड है अनलेस अनटिल कि हम साथ में सोचें कि थैलेसीमिया ट्रेट को साथ में गिलबर्ट्स भी हो गया जो कि एक कॉमन एसोसिएशन है। अदरवाइज थैलेसीमिया ट्रेट जैसा मैंने बताया ना आपके पास ट्रांसफ्यूजन और स्टेनोमेगाली के साथ नहीं आएगा, राइट?
Ma'am, can you go back to graph again? Go to graph again.
Yeah.
Okay, so what is unusual that you have not seen in previous graphs?
Pre-integration.
Anything unusual you have seen over here?
Bilirubin
Yes, yes. कौन बोला? सारंगी? नहीं. Who answered?
bilirubin peak.
Bilirubin peak. Okay, there is a bilirubin peak you can say, but pre-integration peak किसने बोला? अरे सही जवाब बोला बिल्कुल. कोई वो अवार्ड लेने के लिए सामने नहीं आ रहा.
Neelu here, ma'am.
Yeah, Ninu. Okay. So these are pre-integration peaks. Very nice. So normally if you see in the graph which Dr. Dinesh had shown, normally this line is a kind of a flat line. You don't have any peaks between 0 and, or there might be some small peaks. But this kind of a pre-integration peak is usually suggestive of something. But if you also read the graph, आपका F is 0.6% and A2 is 2.1%. What is the normal cutoff for A2?
2 to 3.5.
2 to 3.5. 2.1 is, I would say, on the lower end of the spectrum. So when I have these pre-integration peaks and I have an A2 on the lower end of the spectrum, I should start thinking of
HPH.
very good.
Alpha thalassemia.
Alpha thalassemia, right? So HBH. So why did I put this case again? Because this was also again a symptomatic patient in the terms that he was like a thalassemia intermedia like picture. So आपके पास कभी कोई patient आता है with this kind of a history of on and off transfusions, some anemia, some maybe gallstones, some splenomegaly. So ये आपके DDs होने चाहिए. You can look at the ethnicity. If you get कि ये north east से आया है तो E would come up on your DD. अगर आपका HPLC आगे 2.1 दिखा रहा है and you may or may not sometimes have these pre-integration peaks also, still you should suspect कि HBH disease तो नहीं. So what should be the next investigation? Anybody, what is this?
Reticulocyte progression.
Reticulocyte.
Very nice. So this is
Diffusions.
the incubated reticulocyte preparation, and what does it show you?
Gall ball inclusions.
And why are these gall ball inclusions formed?
These are tetramers forming inclusion balls.
Very good. So हमारे पास तीन HBH disease means 4 alleles of alpha chain alpha genes, and when 3 are knocked out we call it as HBH disease. जब 3 अल्फा चेन्स लॉक्ड आउट हैं तो बीटा ग्लोबिन चेन्स किसके साथ कंबाइन करेंगी जाकर HbA बनाने के लिए? तो उनको क्योंकि कोई नहीं मिलता, so they kind of form tetramers and they precipitate within the cell and they result in the formation of this gall ball inclusions. So this is another simple test which can be done in the lab. जो HPLC नहीं भी का हो वो भी CBC findings देख करके you should always go ahead and do an incubated retic in that kind of a sample and supplement it with that HPLC finding. We can say that this is a case of alpha thalassemia. And this is how this patient graph would look like in a case of capillary zone electrophoresis, where there is a separate zone where this Barth's hemoglobin is eluted in HB capillary zone electrophoresis, and it is a better technique to pick up alpha thalassemia subtypes. And get this case worked up, so we were able to show that there is alpha 3.7 deletion and a diagnosis of alpha thalassemia was suggested. Okay, so Dr. Mukul, HBH disease कैसे आता है आपके पास?
But this is the classical presentation. So this is a classical presentation which you have discussed. So most commonly it is like this only. Adolescent or young adults, they present with intermittent jaundice, occasionally requiring transfusion. Some of them may have higher transfusion requirements also. We suspect
any specific treatment for these patients?
अभी तो कुछ नहीं है मैम. Transplant. They are transplant dependent.
Right.
So
Okay.
एक इंटरेस्टिंग चीज रहता है, कभी कभी जो थैलेसीमिया बीटा थैलेसीमिया ट्रेट वाले पेशेंट्स हैं, sometimes if they are having jaundice and mild splenomegaly. So that is one condition where they can have a coexisting alpha thalassemia trait also. So that is something which you can just keep in mind, that beta thalassemia trait can be coexistent with the alpha thalassemia as well.
Right. Okay. So then, case 6, we have a 23-year-old male with history of jaundice on and off, and again moderate degree of anemia, some mild microcytic hypochromic indices, and the smear is showing anisopoikilocytes, microcytes, elliptocytes, few polychromatophils, and this is what the HPLC is telling me. So, Mukul, तुम भी participant हो क्या?
मैम मैं हूँ.
हाँ, okay. So Mukul, अच्छा चलो मजाक हो गया. Diljot, can you tell me what is abnormal in this HPLC graph?
A2 concentration is very less. It's 1.6.
Right. And then what else?
Total hemoglobin is 2.3, which is more into like 23-year-old male.
Okay. Anything else in the graph?
Anything else? Just initial of the graph. Look carefully.
There is a peak in the integration.
ओके, बट अगर जॉन्डिस होता है तो बिलिरुबिन की वजह से भी ये पीक आता है, तो वो कई बार इट इज देयर बिकॉज ऑफ बिलिरुबिन आल्सो. एनीथिंग एल्स? एनीबॉडी? एनी वॉलंटियर्स?
Another peak corresponding to 2.99.
यस, वेरी नाइस. सो इसीलिए मैंने वो बोला था, जो दिनेश ने बोला दैट व्हाट इज माय फेवरेट स्लाइड, व्हाट इज, है ना. सो नॉर्मली आपको एक के बाद इस तरह का कोई पीक नहीं दिखता है. So at a retention type of 2.99, you have an abnormal peak. Plus, if you look at the baseline, this is slightly shifted upwards. Normally, when you interpret the graph, आपका ये line straight होना चाहिए. So we did rerun the sample, and somehow because of this abnormal hemoglobin, ये pattern ऐसे ही आ रहा था. And the percentage आपको of this abnormal hemoglobin, you can see from here, it is telling you in this graph that there is an unknown peak at 2.99 with a percentage of 7.8%. Right? So we have some variant hemoglobin chain which is eluting at that time point. Normally अब हमारे लैब में ऐसा सैंपल आता है तो हमने स्टैंडर्डाइज कर दिया कि हमें नेक्स्ट स्टेप क्या करना है. Can somebody tell me what is the next step? Can you tell me another investigation which we should do?
Electrophoresis.
Electrophoresis, good, very nice. We should do an electrophoresis. Unfortunately हमारे पास अभी सेटअप नहीं है तो हम नहीं करते हैं. If it is an alpha thalassemia, we can have some fast moving bands and HB electrophoresis which will come after the adult hemoglobin. What else? Plus, वैसे भी it is a rule when you say that you have some variant hemoglobin, ideally you should show by 2 tests. But because now HPLC has become such an easy walkaway system कि आप उसको supplement कर लेते हो by a parental screening. So doing those 2 tests is, I would not say that parental screening is a replacement, but yes, it helps you to confirm your diagnosis. So I'll not waste any more time, and the next investigation which we do in our lab is a, so again suspected case of आ गया. पहले question answer बताओगे तब बताऊंगी आगे क्या टेस्ट क्या करेंगे. So again a suspected case of, based on the history that it is not a trait, it is a major, it's falling somewhere in between. Then you have probably a unstable hemoglobinopathy is one differential which we keep here in our lab. Then you have a mild microcytic hypochromic picture. इस unstable hemoglobinopathy में alpha mutation या alpha chain alpha thalassemia होने के chances काफी high हैं because your A2 was low, right? And unstable hemoglobinopathy के लिए या कभी इस तरह का abnormal chain आए, so the diagnosis can ideally be confirmed only by sequencing. But before you go for sequencing, if you are really suspecting an unstable hemoglobin, you should do a heat stability test. And this is a very simple test. Unstable hemoglobin में क्या होता है, alpha और beta globin chains का आपस में interaction is weakened. So what will happen when we prepare a hemolysate and hemolysate in a tris HCl buffer in water bath at 56 degrees centigrade or 50 degrees centigrade, though ये chains हैं, they are unstable and they will precipitate. But normally, in a normal adult sample, these chains will not precipitate. So if you see in the control tube, there is nothing here, and then in the test, you can see that there is a precipitate of these abnormal protein. So I'm really thankful to Dr. Dinesh for standardizing this test, and it has actually helped us to pick up and move one more step forward, at least in the diagnosis of some of the cases. And eventually, इसके बाद मैं कुछ नहीं कर सकती. It is likely that the parents' sample would come out to be normal. There's one more thing कि unstable hemoglobinopathy में ऐसा लिखता है book कि normally you can how long can you keep a sample before you run it on HPLC or HB electrophoresis? Anybody? आज मैंने सैंपल दिया तो कितने दिनों के अंदर लैब को सैंपल रन कर लेना चाहिए?
Within a week if it's refrigerated.
Yes. So usually within a week, otherwise you will start getting a high peak of the degraded or the degenerated hemoglobin. So within 7 days, और क्योंकि unstable hemoglobin को लेकिन अगर हम कहते हैं 7 days के लिए store किया, it might get degraded and then you might get a normal HPLC pattern, right? So what we have sometimes now started doing is कि अगर हमारे पास इस तरह का clinical picture आता है और कोई HPLC पे abnormal peak नहीं भी आता है, तो भी clinically if it is being suspected that it seems to be a hemoglobinopathy and we should rule out that कोई unstable तो नहीं है, so sometimes we do subject those samples to heat stability test and we have seen कि हमारा test positive आ जाता है, which probably suggests, unfortunately this is not supplemented by a molecular diagnosis in all the cases. That is where you then get stuck and you find it difficult to label. This is courtesy Professor Reena Das lab. ये sample we had forwarded and this was diagnosed as hemoglobin sun-triarid where they worked up the case and there was a homozygous missense mutation. So this is I have just shown this example to tell you कि HPLC unstable hemoglobinopathies या कुछ hemoglobinopathies में sometimes your graph might be near normal or it might show you just some abnormal peak, and in those cases eventually if you want to actually get a diagnosis, these are those cases जहाँ आपको molecular करना पड़ेगा. D सोच रहे हो, E सोच रहे हो, sickle सोच रहे हो, लेपोर भी सोच रहे हो या ये तो it might not be mandatory to actually go ahead for a molecular panel, but in such cases you would require molecular testing. So towards the end, so we have spots. Here we have a case where HPLC-F is 15% and A2 is 3.4%. Then there is a peak of almost 70-80% after A2 at a retention time of 4.3. So diagnosis, Diljot?
Because retention time is 4 point, I mean it's after the A2 peak, it can be HBQ.
HBQ के लिए percentage abnormal नहीं है, 70-80% HBQ नहीं होगा. HBQ is a beta thalassemia variant or an alpha thalassemia variant? चलो अच्छा कोई बात नहीं. So मैंने एक पर्टिकुलर केस स्पेक्ट्रम नहीं दिखाया मैंने और दिनेश ने, जिसके लिए मुझे डॉक्टर मुकुल ने टोका था. So what do you think this could be? Again, if you look at the plot, there is no normal HbA, है ना, right? The HbF is increased and then you have a peak after A2 which is a retention time of 4.39. तो E तो है नहीं, right? And I tell you the patient is symptomatic abdominal pain at maybe 7-8 years of age. Right, sickle cell, right? So this is a case of homozygous sickle. A2 अगर sometimes glycated sickle hemoglobin can also come in this A2 region, and suppose ये 4 या 4.5 होता अगर A2 concentration, so we should have gone ahead and done a parental screening to see whether it is compound heterozygous sickle and beta or is it homozygous sickle. Next plot. Here we have, this is an asymptomatic individual with hemoglobin 7.5%. Pregnancy में हमारे पास detection के लिए आया, and you have a peak which is immediately after A2. And because D Punjab starts eluting even before A2 complete हो पाए, इसीलिए frequently D Punjab के साथ A2 is slightly on the lower side. So this is a condition जिसमें आपको साथ में alpha thalassemia नहीं सोचना है, right? इसका clinically if you see a homozygous D Punjab patient would be asymptomatic and this kind of a test would be picked up incidentally in a lab, maybe a pregnant female who's come for a routine ANC checkup. And this is something, इसको we call it very frequently in our lab as the twin tower kind of a thing. What do you think is very good? So this is D Iran where it is the peak is almost looking like that. similar to the adult A hemoglobin? And why is it not E? Ninu? Why did you not say hetero HBE? No answers? मैंने बताया था ना हेट्रो HBE का परसेंटेज इज यूजुअली बिलो 30%, whereas HBDs के परसेंटेज आपके आएंगे between 40 to 50%. So this is the case, suspected case of HBD Iran. So I think I'll just quickly sum up. If you have a case who's come to you with anemia, suspected hemoglobinopathy, these are the basic investigations which you need to do. Ethnicity is important. Look for sickles. Do a sickling test because your sickle homozygous sickles का भी CBC से कोई clue नहीं मिलेगा. Go ahead and do HB electrophoresis or HPLC or capillary zone electrophoresis, whatever technique is available in your lab. If it is positive, then try and pick up what kind of a diagnosis is likely, where in the clinical spectrum does the patient come, is he asymptomatic, is he symptomatic, is he requiring transfusions and so on, and then parental screening will eventually give you the clue, right? And if all these are negative, these techniques are negative, but still there is a strong suspicion of a hemoglobinopathy, then sometimes you will actually have to go ahead for doing a molecular testing. And otherwise हम molecular testing करते हैं जैसा दिनेश ने बताया था for antenatal patients where we if both carrier have married, both the husband and the wife are carriers, there we need to do a antenatal testing for which we do a molecular testing. That is the last slide, I think. That is the last slide. Okay. So